cardiomyopathy in the sense, and hence it's not been classified as a cardiomyopathy according to AHA or ESC. When we come to epidemiology, ischemic cardiomyopathy is quite prevalent. It contributes to nearly 50 to 60% of all heart failure. Also, it has high mortality, with 1-year mortality being as high as 16% and 5-year mortality being around 40%. So why is it important to identify ischemic cardiomyopathy? Because the treatment options differ. Revascularization, when it is feasible in these patients, becomes important modality of treatment along with the GDMT. And what are the modalities we have to identify? Number one being echo, because it's easily available. The other modalities other than echo being cardiac MRI, nuclear scan, and of course coronary angiogram. So coming to the etiology, overwhelmingly obvious cause for ischemic cardiomyopathy is atherosclerosis. However, there are a small percentage of patients who can present with non-atherosclerotic causes of ischemic cardiomyopathy. And these could be coronary anomalies, coronary artery spasm, vasculitis, and in patients with normal coronaries, it could even be due to microvascular dysfunction. So coming to the 2D echo features, so just like any other heart failure, you could see dilatation of left atrium, left ventricle. However, the hallmark of ischemic cardiomyopathy is presence of regional wall motion abnormalities. Also, the patient could have LV diastolic dysfunction. You may see sometimes thinning of segments, and mitral regurgitation also can be present. So regional wall motion abnormality, I have a few things to say in this. So commonly we see some reports where patients come with just one segment, basal inferior segment being hypokinetic, and the patient being branded as ischemic heart disease. It's very important to note that these two segments, the basal inferior and the basal septal segments, have inherently reduced motion, and this is mainly due to the tethering that happens to the mitral and aortic fibrous structures. So what is more important is to look for wall thickening that is present or not. So if the wall thickening is happening, it's very unlikely that the segment is ischemic. And the subendocardial half of the myocardium receives more blood supply, and it contributes maximum to wall thickening. So not just hypokinesia, also assessment of wall thickening is important in segments, especially when you want to evaluate segments which are adjacent to the ischemic or the infarcted ones, where tethering can play an important role. The other important things in echo that we see are these two entities called tardokinesis and post-systolic contraction. Tardokinesis is defined as delay in the onset of systolic contraction, and post-systolic contraction means that the contraction is happening in the isovolumetric relaxation period beyond the systole. So I'll show you in the further slides how this can be identified. So this is a parasternal long axis view of a patient which is showing dilated LALV. The regional wall motion abnormality is very obvious. The anterior segment is looking hypokinetic and thinned out. And this is the 4-chamber view, again emphasizing on the regional wall motion abnormality affecting the LAD territory and presence of mitral regurgitation. And when you come to the short axis view, you can see the wall thickening is definitely preserved in the inferior segment, whereas the wall thickening is not happening in the anterior territory. So how do we identify whether these patients have ischemic cardiomyopathy when the regional wall motion abnormality is not present at rest? So when rest study is not showing RWMA, it is important to do a stress echo in these patients, where the hallmark of ischemic cardiomyopathy is presence of a biphasic response, which is when you give low dose of dobutamine, there is an increase in contractility which happens transiently. However, when you step up the doses of dobutamine, these patients will have worsening in contractility. This is the typical biphasic response that happens for stress. This is indicative of a significant epicardial stenosis in such patients. Also, LV cavity dilatation, which happens with stress, also indicates left main coronary artery disease, or it could be due to multivessel disease. This is a quantitation of mitral inflow E by A and E by E prime ratio that is shown both at rest and during exercise, post exercise. So here you can see at rest the E by E prime is 6.5. However, when the patient was made to exercise and stress echo was done post exercise, the E by E prime went up to 13. So this indicates that there could be probability of underlying ischemic heart disease. So this is the typical biphasic response that I told. This is actually tissue Doppler of an inferior ischemia patient. Here you can see the left upper quadrant is at rest, and the right one is with low dose dobutamine, and the below one is with high dose dobutamine. So here you can see that the the S prime velocities go up during low dose dobutamine from 8 to 10. However, when high dose dobutamine was administered, it actually came down to 8, and also the E prime also went up during low dose dobutamine, and again when high dose dobutamine was given, it came down significantly. So this is the concept of tardokinesis that I was talking about, which can be seen in strain rate. So when you do the strain rate indicators of ischemia, so here you can see that it takes, when the patient is at rest, this is the TS, which is the onset of systolic contraction, which is short. However, when the patient was given dobutamine, the onset of systolic contraction gets delayed, and also the excursion, the S excursion gets reduced, and you can see that it is extending beyond the systolic contraction into the IVRT period. All these three things are suggestive of ischemia in this patient. So, is there any objective way of analyzing whether these patients have ischemia or not? Yes, speckle tracking helps us to find out whether there is objective evidence. It can assess longitudinal, circumferential, and radial strain, and it is less angle dependent, and rapid semi-automated analysis can be done. And the ease of analysis is there in assessing both global and regional peak systolic strain, and this is all displayed in a polar map format, which is very easy for us to understand. So this is the polar map at rest and at stress for the patient, same patient. And here you can see at when the patient was made, the stress echo was done, the GLS dropped from -14 to -9.1. And there is unmasking of regional wall motion abnormality in the anterior lateral territories, and only the inferior territory is non-ischemic. And this patient had multivessel coronary artery disease. So this is a spotter for the postgraduates. This is a rare cause of ischemic cardiomyopathy that is recognized by echo. So as I said, echo is not just going to diagnose. Rarely you can also find the cause for ischemia. So this is a young patient where you can see LA and LV is dilated and significant mitral regurgitation is there. And this is short axis view across the pulmonary artery where you can see some collaterals. So the diagnosis was actually Al-Kappa in this patient. So it's important to also recognize that echo is important to diagnose the cause of ischemic cardiomyopathy too. So ischemic cardiomyopathy is a frequently diagnosed condition, and 2D echo remains the first imaging of choice to diagnose and to rule out other causes of LV dysfunction. Regional wall motion abnormality, when it is present, it is obvious, it helps us. However, absence of regional wall motion abnormality does not rule it out. So stress echo can unmask this regional wall motion abnormality, and strain imaging adds objectivity to the diagnosis. Of course, coronary imaging always confirms it, so we will have to eventually do that as part of workup. Thank you.
Good afternoon, and thank you, Dr. Sunil Bohra and Dr. Satish Govind, for giving me the opportunity to present in this prestigious forum. When we're just trying to learn how to do LV diastolic dysfunction and trying to correlate, now comes RV diastolic function to make our life a little more difficult, I think. But then cardiologists have known to be more LV-centric. We are more bothered about the LV. And now we have started looking more and more into the RV. Now, if we want to classify in a simple way, RV failure can be pressure overload, volume overload, and myocardial disease. Here I'm omitting the pericardial diseases because it's a different pathophysiology altogether. So maybe a busy slide, but to just tell you briefly, Pressure overload, if it's acute, is mostly because of pulmonary embolism, and chronic is because of all the types of pulmonary hypertension that we know. And volume overload is because of tricuspid regurgitation or pulmonary regurgitation, either because of structural or functional, and many congenital heart diseases. And myocardial diseases, there are umpteen, especially RV, myocardial infarction, arrhythmogenic RV, cardiomyopathy, myocarditis, so on and so forth. The commonest cause of RV failure that we all know is pulmonary hypertension. But epidemiologically speaking, the commonest cause of pulmonary hypertension is LV failure. So RV failure is the final common pathway for LV failure. So that is why we have to assess this RV failure. Of late, we have all known to assess the RV systolic function, where TAPSE, RV, S- from tissue Doppler velocity has been a common practice in most of the echocardiography practice. And there are other things like 3D echo assessed RV ejection fraction, FAC, and GLS has been lately used frequently. And RV diastolic function has been not even assigned like quarter page in the AAC guidelines. They have given one table and a few paragraphs. That's all we can find about RV diastolic dysfunction assessment as far as AAC guidelines is concerned. So there are again like LV diastolic function, you have to assess the E, A, E prime, A prime, E by A prime, IVRT, DT, everything like LV diastolic dysfunction assessment. But in our routine practice, we don't do it. But in pulmonary hypertension, we have to focus on it. Now, why do we have to focus on it? This is what? This is the regular thing that we do in the LV. Now we have to start doing in the RV. IVCT, IVRT. Now, according to the ASC, we again have the three gradients or the classification of RV diastolic dysfunction as impaired relaxation, pseudonormal filling, and restrictive filling. And we have the guidelines which say that E by A ratio less than 0.8 and so forth and so on. We find it in the latest ASC guidelines. And always associated features, friends are known by their associations. The friends or the pathophysiology of LV diastolic dysfunction is RA dilatation and IV collapsibility that we routinely assess. Now, let's see why we should. Now we know how to assess the RV diastolic dysfunction. Why should we do it? Why should we do it? Because the number of papers are coming out of late. But as late as 1996, this paper was published where RV diastolic dysfunction was assessed in heart failure. And interestingly, this paper suggested it is not only seen in patients with pulmonary hypertension, but also in patients without pulmonary hypertension, which makes it a little more interesting. Now, coming to pulmonary hypertension, what happens in pulmonary hypertension that leads to RV diastolic dysfunction? So there are many, this is an elegant study which was based on MRI, which showed that RV diastolic stiffness is contributed by increased collagen and intrinsic stiffening of the RV cardiomyocyte sarcomeres itself. At the cellular level, the changes take place. Now, this is an original research article. It's a beautiful article which studied the diastolic dysfunction assessment in pulmonary hypertension. We all know right heart catheterization is the gold standard that we don't perform as frequently as it was done previously. And RV end diastolic elastance is supposed to be the gold standard marker for RV diastolic dysfunction, which I don't think we are doing it. But echocardiographic parameters, if it can act as a surrogate for this RV end diastolic elastance, could help us to prognosticate is what this research people had proposed. And they had found one surrogate marker, that is RV S prime to RA area index. So this is correlated with, rather than the E by E prime or other annular velocity, nothing correlated with the prognosis. We all know RV diastolic dysfunction exists, but does it correlate with the prognosis? Does it help us clinically? This study has given us one ray of hope. Maybe the echo-derived S prime bar RAA index may correlate with the RV diastolic dysfunction, which in turn correlates with the prognosis of patients with pulmonary hypertension. Not only, there is a whole new subject, a different subject of operated congenital heart disease, especially TOF, where diastolic dysfunction has been studied extensively. And this journal, 50% of the patients with operated TOF had diastolic dysfunction, and ventricular tachycardia was more common when the patient had diastolic dysfunction. So there are a lot of new things happening in the RV, sometimes called the orphan ventricle, the forgotten brother, but we never forget the RV. We also try to assess the RV in line with the LV. If it helps us to prognosticate the patient and if it helps us to prognosticate the patient and escalate the treatment, why not use that modality also to assess the RV? Thank you for your patient listening. Thanks.
That we had seen a couple of years ago, 42-year-old diabetic hypertensive presented with progressive chest pain. Physical examination was unremarkable, ECG normal, and echo was showing a dilated ascending aorta, aortic root was dilated, and there was a mobile structure that was seen prolapsing into the LV with severe aortic regurgitation. Further evaluation showed a circumferential tear of the aortic root, causing a severe aortic regurgitation. CT aortogram also was done. So it was a very unusual or a very rare finding to see a circumferential intimal tear that was seen to telescope into the LV. And this is also called as intimo-intimal intussusception. Very rare, less than 2% chance. With this in background, let's go into understanding aortic regurgitation a little more. AR is always pathological. It results basically from valve cusps or from alterations in the anatomy of the aortic root or LV outflow, basically the supporting structures. So most common etiology among the congenital is the bicuspid aortic valve, which has an autosomal pattern with incomplete inheritance. With pure AR as presentation with bicuspid aortic valve, the presentation is usually in the first 2 decades. Other congenital anomalies which can lead to aortic root dilatations and thereby leading to an aortic regurgitation is connective tissue disorders, annular aortic ectasia. These were few echo images which was actually a bicuspid aortic valve. Short axis is missing, but it's a bicuspid aortic valve with severe AR. Most common among the acquired disease are the rheumatic heart disease, which has other features of other valve involvement, mitral involvement, secondary tricuspid regurgitation involvement. Other common causes are degenerative valvular heart disease, where you can see a more calcified aortic valve, combined AS-AR-like pattern, i.e. less common but still very frequently encountered in clinical practice. Pathology remains just 2 more important. One, aortic root abnormalities or leaflet abnormalities. In the aortic root abnormalities, you basically see the aortic root dilatation, which can be beautifully classified with the Carpentier classification. Further, because of the root dilatation leads to aortic dissection, which is also very frequently observed, leading to a severe aortic regurgitation. Other one is the aortic leaflet abnormalities, where you can have a prolapse, a perforation, or a leaflet tear, or associated vegetation with the leaflet, which can lead to a severe aortic regurgitation. Pathophysiology varies between acute AR and a chronic AR. Acute AR presents more acutely, has sudden increase in LV volume, causing a massively increased LV end diastolic pressure and a left atrial pressure, leading to much more aggressive symptoms like pulmonary edema. Patient can present with myocardial ischemia because of the coronary filling in diastolic phase is compromised. Patient can also present as shock. Whereas in chronic aortic regurgitation, the symptoms are more long-lasting and the LV adapts to the chronic volume overload situation. Here also there's a bit of LV increased end diastolic pressure and increased left atrial pressure, which presents as dyspnea for the patient. And because of the progressive LV dilatation and hypertrophy, that pounding sensation, palpitations also very common. This AR presents morely like a pressure and volume overload situation. So both eccentric and concentric hypertrophy of LV is also noted. And there's subsequent decreased stroke volume that you see, decreased forward blood flow, and systolic heart failure that associates to this condition. Most of the patients have long asymptomatic period. Symptomatology starts about 4th to 5th decade. Presentations, like I was just mentioning, varies from acute and chronic. Acute will not have much of clinical signs, but symptoms, yes, they present more acutely: pulmonary edema, failure, shock. But chronic have a very progressive symptomatology: angina, dyspnea, palpitations, can also present with dizziness or syncope because of the decreased forward output. Diagnosis is predominantly by echo. Both TTE and TE help defining etiology and classifying and assessing the severity of AR. Cardiac CT basically to assess the aortic root anomalies or dilatations. Cardiac MRI to assess the volumes, less frequently used, but predominantly it is the echo. So there are few important indications for echo in AR to assess the presence and severity, to assess the etiology. Aortic root and LV dimensions needs to be assessed, and all these have to be reassessed and reevaluated sequentially, especially in patients who are asymptomatic. Asymptomatic aortic regurgitation, about 3.6% of individuals progress to becoming symptomatic. And if there's an onset of LV dysfunction, easily about 25% become sooner or later symptomatic. So it's always important to screen these patients, asymptomatic AR patients, at least 3 months to 6 months, reassess intervally to assess the LV dimensions, root dilatations, and to see how fast they're progressing. Going into the details of echo, 2D imaging has much more important role to assess the leaflet morphology, number of leaflets, calcification, to assess basically the etiology, and it's well described in the Carpenter's classification. It basically helps to understand the mechanism of AR. It classifies the AR based on aortic root and leaflet morphology. There are 4 types, I'm sure you all know, but type 1 is where you have a normal leaflet motion, but enlargement of aortic root. So either the annulus is enlarged or the STJ junctions are enlarged or the SOV is enlarged, based on which they are classified. Type 2 is cusp prolapse. We earlier saw a cusp prolapse, which can also lead to severe AR. Type 3 is restriction. These are predominantly the degenerative types of valves where you have calcified aortic valves leading to both, can be both AS with AR or pure AR also. Assessment of LV dimension and root dimensions are of utmost importance, and sequential interval dimension assessment also becomes important. So the red flag signs are LV end diastolic diameter more than 65 mm and systolic dimension more than 50 mm and LV EF less than 50%. Ascending aorta for few categories more than 45 mm, and for predominantly anybody more than 50 mm needs to be alarmed and should be referred immediately. Doppler methods predominantly help to assess the severity. There are few qualitative, few quantitative and semi-quantitative parameters or tools that we use to assess the severity of AR. Color flow Doppler being the most common, semi-quantitative, not very specific. Few parameters are very good to assess. Jet width and LVOT diameter can be assessed, and anything more than 65% would account for a severe aortic regurgitation. The problem with this tool is it underestimates AR in eccentric jets and overestimates in central jets. That is why it is semi-quantitative. The next tool is the jet area versus LVOT area. Less specific and sensitive, not quite frequently adopted. Vena contracta, very much important. So here the challenge is to attain the convergence point and to assess the diameter. So it is advantageous to assess jets which are eccentric also, but problem is in presence of multiple jets or presence of bicuspid valves, and you need to visualize the convergence zone very carefully. Flow convergence, again, qualitative assessment to assess the severity. This is more of a supportive value to assess severity of AR. Flow reversal, it has much more sensitivity and specificity when taken in abdominal aorta. In presence of reverse flow in abdominal aorta, it clear-cut indicates a severe aortic regurgitation. Continuous wave Doppler to assess the density and to assess the jet deceleration time. Again, semi-quantitative tools to assess the severity of AR. When pressure half time is less than 200 milliseconds, it's a severe AR. Any pressure half time more than 500, it essentially rules out severe aortic regurgitation. Again, like I was telling, it's a qualitative tool, so not much of a significance. There are few important parameters that we assess to quantify the severity of aortic regurgitation, like regurgitant orifice area, regurgitant volume, and regurgitant fraction. A lot of calculations required, a lot of assessments involved. Last but not the least, but stroke volume method is also one of the tools that you can use to assess the severity. Here the challenge is to assess the mitral annulus diameter. That becomes challenging, but otherwise it's a good method to assess the total volume that goes through the LVOT and mitral valve to finally judge about the severity of AR. TE also has similar role, not much frequently adopted because TTE gives equally good results. Here, role is to assess the morphology of the valve and aorta and to assess the mechanism and etiology of AR. Severity criteria for aortic regurgitation based on the echo parameters, some qualitative, some semi-quantitative and quantitative methods. It's a mechanical problem, so the answer remains mechanical. You need an aortic valve replacement. Most often it's surgical. Of late, there's some studies on transcatheter as well. Medical therapy remains only to patients who are in heart failure for supportive therapy. So management predominantly depends. Any symptomatic aortic regurgitation will definitely require a surgery. For patients who are asymptomatic, you can use the 50-50 rule where the LV and diastolic diameter is more than 50 mm or LVEF of less than 50%, that's the point where you need to intervene, or presence of other associated factors like aortic root dilatation more than 50, you need to intervene, provided if there's a severe AR associated with aortic root dilatation, you have to fix the valve as well. Otherwise, just go with a valve sparing procedure. Last on, before we conclude, this is the recent update. This is the GINA valve, which is a bioprosthetic heart valve, porcine based, which is currently approved for an investigational device for the Align AR trial, and it's soon expected to be launched for clinical use. It is basically indicated only for a pure aortic regurgitation. For TAVI, combined AS-AR is still not a contraindication to go ahead with TAVI, but this was a valve that is currently being approved for pure AR. Thank you.
I'll be discussing case-based scenarios pertaining to echocardiography. This is mainly based on congenital heart disease. At the outset, I would like to thank the organizing committee of IE Karnataka for this opportunity, Dr. Sunil, Dr. Satish Govin, and all the faculty members involved. So this was a 3-month-old female infant who was hospitalized for frequent respiratory infections. In fact, she was hospitalized second time admission. The cardiomegaly was noted on chest x-ray and hence a cardiac evaluation was asked for. In retrospect, that is after coming to the diagnosis, when we asked a little bit into history, there is some history of excessive crying, irritability, feeding issues and fast breathing. The pediatrician, due to the cardiomegaly on chest x-ray, asked for a cardiac evaluation. And baby was tachycardic, tachypneic. All peripheral pulses were well felt. The first heart sound was normal, and there was a loud second heart sound with an LV-S3, but no murmurs were appreciated. And there was hepatomegaly on per abdomen examination. As I said, cardiomegaly noted on chest X-ray with pulmonary congestion. So this was the echo picture noted in this baby. As we all see, there's hugely dilated left ventricle with LV dysfunction and almost moderate pericardial effusion. And also we see that the left ventricular papillary muscle and the chordae tendineae are quite hyperechoic, and these suggest ischemia of whatever the cause. On further imaging, and also there was mitral regurgitation noted on color Doppler. And on this is parasternal short axis view. As evident in this, we see that the right coronary artery is dilated and the left coronary artery origin is not from the left aortic sinus as we normally expect. If we closely look at the pulmonary artery, we see the left coronary artery arising from the pulmonary artery from the lateral aspect. When it arises either from the lateral or the posterior aspect, it's a little easier for the diagnosis of L-kappa, or what we commonly know as anomalous left coronary artery from pulmonary artery. But when there is a medial origin of coronary, it may be a little difficult in imaging for this L-kappa. So on color Doppler, we see that the coronary flow is from the pulmonary artery, antegrade flow. It's important to reduce the color Doppler Nyquist limit when we're imaging the coronary arteries, the venous flows, all these structures. Ideally, we should do that. Here, it's not been done. So a diagnosis of L-kappa was made in this infant. It's often a high index of suspicion to make a diagnosis of L-kappa. Many of these infants are being even now followed up as dilated cardiomyopathies. So when in doubt, always it's better to do a coronary CT in these children who are being treated or followed up as dilated cardiomyopathy. So classically, we see that there is scarred and thinned out myocardium at the anterolateral LV, while the posterior-basal part may show hypertrophy and hyperfunction. Features such as hyperechogenicity of the papillary muscles, endocardial fibroelastosis, and MR are almost always present, and these are indirect evidences to say that this could be L-kappa. But the most important is to demonstrate the origin of the left main coronary artery from the pulmonary artery, which is the direct evidence. So sometimes spurious aortic origin can be created due to the presence of fluid-filled transverse sinus of pericardium, and this can artificially mimic the origin of the left coronary artery. So if we are concerned about the coronaries in a dilated cardiomyopathy infant, especially less than 6 months, it's important to get a coronary CT angio done. So it is an important cause of DCM-like picture in infants. High index of suspicion and meticulous echo evaluation is the key to accurate diagnosis, because this is a completely correctable situation with really good long-term outcomes. So surgical intervention results are very good in the present era, hence the importance of an early pickup in these babies. This is a very interesting case. Recently, we had to deal with this child. I'm sorry, I don't have very good echo images of this since everything was bedside and done in kind of an emergency situation. So this was an 8-year-old child who was previously thriving, well, normal child who went to school on a morning on 8th of January. And suddenly during her PE session, she complained of intense chest pain and shortness of breath, came down to her PT teacher and said she has these complaints. And she almost fainted, but she was not unconscious. But she didn't complain of any palpitations or there was no history of trauma or fall. So she was initially taken to Manipal Hospital, Vartur Road branch, to the pediatric emergency. And the pediatric intensivist there got in touch with our team because she was very hypotensive with desaturation, prolonged CFT and BP. In spite of multiple inotropes, we could not get the BP to more than 5th centile. And in fact, cardiovascular system was very unremarkable, but the echo done at the referral hospital showed global LV dysfunction with an EF of 30% and a reduced RV function with severe pulmonary hypertension. Since myocarditis or an arrhythmic event was first in our diagnosis, coronaries were meticulously imaged, but it was thought to be normal. So this is the ECG done at Manipal Vartur, which shows lead 2, lead 3 AVF ST segment depression and a slightly elevated in AVR and AVL. ABG showed severe metabolic acidosis with respiratory acidosis. And since child was in hypotensive shock, the ECMO team rushed to Manipal Vartur branch. She was put on ECMO there within 4 hours of hospital admission and retrieved to Old Airport Road branch. And she continued to be on ECMO support for almost 6 to 7 days. And then when weaning was started, gradually this is where the echo made a lot of difference for us. We saw regional wall motion abnormality. As I said, these are all bedside portable machine echoes. So the images are not great, but we could see clear-cut regional wall motion abnormality, which is a little unusual in children. And also the basal septum and the apical septum of the LV were typically showing significant hypokinesia. And that is when we decided to do a coronary angiogram for this baby. After weaning off from ECMO, a coronary angio was done, which showed the left main coronary artery having a long shaft with narrowing. Initially, in children, the coronary artery disease, what we see in adults, is almost unheard of, and she was an 8-year-old girl, previously normal child. So we decided not to go ahead with any further management like stenting, and instead decided to do a coronary CT the next early morning. So the coronary CT showed the abnormal origin of the left main coronary artery from the right sinus of Valsalva and coursing between here the PA and the aorta in between the coronary. More than that, we can see in this 3D reconstruction that the left main coronary artery, I'm sorry, it's a little slow. We can see that the left main coronary artery is in the wall of the aorta. So this was an intramural interarterial course of the left main coronary artery leading to sudden massive MI, and she had a typical heart attack in the school. And immediately after the diagnosis was made, we took her up for surgery and unroofed the segment which was intramural. She was in the hospital for close to 5 weeks, after which she was discharged with an EF of 45%. This was almost like sudden cardiac death is the most common presentation in these kind of situations. This is also called anomalous coronary artery origin from opposite sinus of Valsalva. The occurrence of ischemia in these situations can be either due to dynamic factors or due to fixed obstruction. So it's a rare anomaly. As I told, sudden cardiac death is usually the presenting the way they present, and exertional chest pain is very important to evaluate in children. Most of the time studies have shown that exertional chest pain and syncope needs much more evaluation for coronary arteries than we are routinely looking at. So this child actually alerted us more and more, and now we are giving more importance to coronary artery imaging. TTE should be supplemented by appropriate investigations including CT coronary angiogram. So this was a 7-month-old baby, again referred as a moderate VST. And she was on follow-up, but somehow, in spite of medical therapy, she was not putting on weight as expected. On examination, she had a normal first heart sound, and the P2 was really a little accentuated compared to a moderate VST, and a pansystolic murmur was noted. So this is, as we closely look at the echo images, we see it's not only the VST shunt that we see between the left ventricle and the right ventricle. There was a significant LV to RA shunt in this baby. So it was a congenital Jabot's defect, wherein there were 2 jets, one into the right atrium and one into the right ventricle. In fact, the presence of RA-RV dilatation in this child made us think more about this presence of Jabot's defect, because in a moderate VST or any VST of a significant size, we see LV and LA volume overload and not on the right side. So this child had RA-RV dilatation with a significant flow into the right atrium directly from the left ventricle, causing pulmonary hypertension. So a diagnosis of congenital Jabot's were made. These are a couple of TE images intraoperatively. Again, as we see, there are 2 jets, one directly from LV into RA and LV into RV. So she also had cleft mitral valve with significant mitral regurgitation, for which repair had to be done. So she underwent surgical repair, patch closure of the VST and the Jabot's defect, and mitral valve repair. And just in 6 weeks, she's almost 6.5 kilos. That's a gain of almost 1.3 kilos. So that's the importance of looking at echoes in children closely when they're not doing as we expect them to. So this is quite a simple case. The reason of presenting this was, it's important to send these children early for surgery. This is a 3-month-old female infant referred for evaluation with a murmur, otherwise totally asymptomatic child. She had a loud second heart sound and an ejection systolic murmur. Parasternal long axis view showing predominantly left to right shunt. I'm using the word predominantly because she also had a transient right to left shunt, and she was a thriving child. So all the more reason to send her, because these babies sometimes are known to go in for early Eisenmenger's features. So this child was operated at 3 months of age. So echo plays a very important role in these situations in determining the type of VSTs, the hemodynamic consequences, and whether a large VST is operable or not. For example, this is another child, 2 years old, with a bidirectional shunting VST. If you are in doubt, we can put a color Doppler M mode across the interventricular septum to profile the color flow better, like as done in this situation. This is a large upper muscular VST. Again, both these children were inoperable. Some features for us to say operable on echo is presence of LALV dilatation, significant left to right shunt demonstrated across the VST, and increased pulmonary venous return. These tell us most likely the child is operable. This is apart from the clinical examination, ECG, X-ray, and then we look at the echo. Most of the times without a cardiac catheterization, we can decide on operability in these children. So this is one of the examples of this baby actually underwent surgical closure at 2 months of age because he was quite symptomatic, but a classical outlet VST or subpulmonic VST, wherein we see that the VST is just below the pulmonary valve. On color Doppler, we see the jet directly going from LV into the pulmonary artery. Also, there is some pulmonary regurg. And these babies definitely need early closure of the VST. Do I have time? One more. So I think this may be in this forum I have discussed previously, but this was again a 22 days old male neonate referred for a diagnosis of PPHN. So this was a very sick baby, immediately required intubation and ventilation. Baby was tachycardic, blood pressure was not recordable, CFT was prolonged, and peripheral pulses were feeble. So this was apical 4-chamber view showing severe LV dysfunction with dilated RA-RV with AST bidirectionally shunting with some mitral regurgitation. So the outside diagnosis was PPHN. And when we looked at the parasternal long axis view, it shows LV dysfunction with paradoxical IVS and a severely stenosed aortic valve. There's hardly any antegrade flow seen across the aortic valve. Initially, it was thought of as unicuspid aortic valve, but after balloon dilatation, we realized it was a bicuspid aortic valve. So this baby had presented like PPHN. So it's important to rule out left heart obstructive lesions whenever we see a neonate with PPHN. So this is post-ballooning. We see good flow across the aortic valve and mild AR. Apical 4-chamber shows improvement in the left ventricular function. So PAH in a neonate should be evaluated meticulously with an echo, and treatable cardiac causes should be excluded prior to starting PAH targeted therapy, especially inhaled nitric oxide. And timely intervention, as in this baby, is life-saving in these kind of critical congenital heart diseases. I thank all of you for a patient hearing.
You all would have been watching a few slides coming on and off. So this is something which happened yesterday. So if you look at the American Society of Echo, it has got 2 verticals. So one is the society, which is the clinical side, and where the guidelines, the meetings, all those things takes place. On the other side, they have another vertical called as American Society of Echo Foundation. So that is a charitable foundation, and they go around the world once in a few years and do charitable work. And about, I think it was in 2013 or something, they came to India and they did a camp, outreach camp in Delhi. And this time they have chosen Bangalore, so they will be coming. And this decision was taken yesterday. And they wanted me to share this with this immediate forum. And that is the reason why I'm showing their slide slides to you. And it's going to be a 1 week sort of event, and primarily there'll be an outreach camp where we'll be screening a lot of echoes. A team of doctors and sonographers will come from the US along with doctors and sonographers from India. This is in association with Indian Academy of Echo. So the sonographers also is the other thing is, apart from that, Bharat Patel, who is a very passionate and very ardent supporter of sonographers and their activities, he sort of said that he wanted me to make this announcement, especially focusing on the sonographers, that there are going to be selections for sonographers who are going to be part of this activity, and you have to be a member of the Indian Academy of Echo National Society, first and foremost, and secondly, preferably if you have American Society of Echo membership, that would help. And he wanted the whoever is interested to send me a message with your CV, and afterwards we are going to sort of go through along with the IAE, so we will come through the selection later. So those of you who are interested, so please reach out to me who want to be a part of this. So there's also going to be a 1-day academic session for sonographers, and then there'll be an academic session for doctors, and it'll be a combined sort of association, both the AAC as well as the IAE. So, and this is for those of you who are interested, just to sort of highlight that AAC is going to have its 50th year, and this is going to be in September. Now, coming to the echo in pericarditis, this will be a focus mainly on chronic constrictive pericarditis, wherein you have pericarditis lasting for more than 3 months, and you look at the guidelines, and there's a specific guidelines on the pericardium, and here echo always has to compete with CT and MRI, and echo has a lot of limitations. So it's very good at picking up pericardial effusions, but when it comes to pericarditis inflammation, the pericardium itself, it's not so good. So a lot of minuses are there, and that's where CT and MRI do much better. And echoes, but the flip side is that echo is the first line of imaging, and that's why it's very important to know your pluses and minuses before you sort of start to diagnose. Now, coming straight to the constrictive pericarditis, the first and foremost is the clinical side of it, and again hammering that same sentence since morning. So as soon as you see a patient on the echo bed and you see a very sort of bulging JVP, and then a patient is wasted and looks very weak and bulging abdomen with a lot of fluid, so start thinking, could this be a possible little constrictive pericarditis? Of course, the heart failures also will present like this. So these are sort of some of the features which they present with, and clinically they will have a pericardial knock or a hepatomegaly and ascites. And if you're in a big hospital, many times you'll see these patients coming from the gastroenterology side because they would have gone there for jaundice, and from there the gastroenterologist refers, and also from the medicine department a similar one. And the etiology is usually infection, and also keep in mind cardiac surgery and also radiation therapy also. And it has its phases. So you have this initial phase where it sort of gets inflamed, it becomes an angry sort of red pericardium, and that is when it sort of loses its elasticity, and then it becomes a little more stiff, and then it sort of starts to you will have some amount of pericardial effusion, and then you have this third phase where you have this resolution. But in some patients this resolution does not happen, and over a period of time it becomes calcific, it becomes fibrotic, and that is when it transforms into chronic constrictive pericarditis. So the normal image tells you the pericardium with 4 chambers having their own independent pressures. So each chamber over there has got its own pressures. But moment you have pericarditis, you have a very stiff pericardium all around the heart, and you have all the 4 chambers sharing almost like equal, there will be equalization of the pressures. So that is why you have the septum moving back and forth as it starts to take in the flow as it comes to the right side and then comes into the left side. So this word which is used is called as ventricular interdependence. You can see that the septum keeps moving from side to side. So this is something which has to be sort of noticed every time when you are suspecting somebody with constrictive pericarditis. So you have, with inspiration, the septum moves to the left side, and then the right side becomes big. And as the patient expires, the septum again comes back to the right side, and the left-sided filling starts to increase. So that is why you have these flows, inflows and out, both on the mitral as well as the tricuspid side, which is sort of increased with inspiration, decreases with expiration. So this is the reason why it happens, as the septum swings back and forth because of the constriction effect all round. Now, the important thing is start with your M mode, and this is something which should be done on a routine basis for every patient you're suspecting chronic constrictive pericarditis. So go for the parasol long axis, reduce the horizontal sweep, and if you have this respirometer, most of the machines do have these respirometers, go back, find out where it is and put it on. So now you have an ECG as well as a respirometer. So you can see that with this, you're able to see that the septum, which should usually sort of curve towards the right side, it has got its up and downs, and with inspiration and expiration it goes back and forth, and this is called as a respirophasic effect. And this is a very, very important finding where it has got a very high sort of accuracy, and if you can establish this, then the next points will sort of start to favor, strengthen your diagnosis. And the respirometer, the upward is inspiration and the downward is expiration. Next is looking at the M mode itself. Now increase the sweep speed and get these cardiac cycles a little better. So you get to see these small projections which are coming in early diastole. So this is the beaking of the septum, and this is called as the septal shudder or the bounce. And this is a beat to beat. The earlier one was respirophasic, while this is beat to beat. And this again is related to the annulus. And also on the opposite side may or may not be there. So you have the diastolic flattening of the posterior wall. So if you are finished with the parasol long axis now, next, looking at the 2D itself. So whether it's in parasol long axis, short axis, or in the fourth chamber, you look closely at the septum. So you see the septum, it has a shuddering movement. So these are sort of very classic patients, and this is something which should never be missed. And sometimes they are very subtle, so that also sort of you have to be very careful. So look for these views, and many times just by looking at them, you know that you're dealing with CCP. When it comes to pericardial thickening, I know that we give a lot of importance, but it is sort of way down on the list. So many a times you may not be able to pick it up. And even if the pericardium is not thickened, not calcified, one can still have constriction. So it decrease the gain and highlight the pericardium so that you get to better see it. And then you do the measurement. And the normal measurement is somewhere around 5 millimeters, 3 to 5 millimeters. Anything more than 4, you know that the pericardium is thickened. And then coming to the next important parameter. So you're looking at the Doppler itself. So this is something which is very familiar to all of you. So you're going to look at the inspiratory and expiratory respiratory variations. And this is both with inspiration and expiration on the right side as well as the left side. And you always will have an E which is taller than A. So that is because of the rapid filling that takes place. So if you have an E which is less than A, then very unlikely you're dealing with constriction. So you have to have a very tall E, and it has got this restrictive pattern, and then you have a very sort of short deceleration time, and you look at the respiratory variation, and if it is more than around 40% for the tricuspid and more than 15 to 25% on the left side for the mitral, so then you know that one more point in favor that you're dealing with constriction. Again, respirometer, again reducing the horizontal sweep, and that is what you have to do. And look at the tissue Doppler itself. So if you get a velocity of more than 8 or 9, you will get some supernormal velocities. It might be even up to 15, 20 centimeters also. Then you know that you're dealing with constriction. And this again is fairly accurate, and you can see it both on the lateral side as well as the septal side. So a high E prime tissue Doppler velocity is in favor. That is especially if it is more than 8-9 centimeters, that is in favor of CCP. then you can do the comparison. So you can look at both the septal as well as the lateral side. And usually in a normal person, the lateral annular velocities are more and the septal velocities are less. But in a patient with CCP, what will happen is because of the pericardium adhering to the muscle over there, it reduces the velocity. So you have a lower velocity on the lateral side and a higher velocity on the septal side. So this is called as annulus reversus. And this is again a very important parameter as I have highlighted. So you see if you can demonstrate. It may not be seen in all patients, but most patients you should be able to find out, especially if the lateral pericardium is affected. Then you also have the annulus paradoxus, where the patient will be having very high filling pressures, but it will come as normal. So these are two different entities. Reversus is different, paradoxus is different. And then this is another one which again we are very familiar. You have a very large non-collapsing IVC, and then again reduce the sweep speed, put on the respirometer, and try to demonstrate that you have a dilated IVC and a dilated hepatic vein. And this is again a point in favor of CP. And lastly, another very, very important point is that look at the hepatic vein, and again reducing the speed and get a good hepatic vein, whichever hepatic vein, whether it's the right or the middle, and then see if you can visually see the color, red color going into it. You know that there is a reversal going on. And when you put on the pulse Doppler and you put on the respirometer, you can see that the expiratory point where the limb comes down. So that is where very sort of rhythmically you can see that point where it is very prominent. So that is called as the exaggerated diastolic expiratory flow and reversal in expiration. So if you can establish, now you have a patient whom you know that you're dealing with constriction. So again, you might find some of them are not there, some of them are there. So you have this table which they have provided. This has come from the Mayo Clinic, and to a large extent sort of fairly accurate, where you have the sensitivity, specificity of each one of them, and then you have this combination. So some of them have very high sensitivity, as you can see in the septal shift and the medial E prime velocity. But when it comes to the hepatic vein, it has got a very high specificity. And when you combine, you sort of further increase it. So these sort of provides you as to which would be sort of helpful. Now you have the strain also. So strain to a lesser extent, it sort of, it doesn't give you any incremental sort of information, but it gives you an explanatory sort of understanding of what's happening. So you see that the strain on the lateral side where the muscle is sort of, held back because of the pericardium. So you have lower strain over there. And this sort of sometimes sort of helps to see even improvement also. And when you compare it with the longitudinal and circumferential, you see that the longitudinal is spared while the circumferential is down. And this again is a color showing that you can see that the septum is red while the lateral is sort of pale. So that again tells you that that side of the wall is not doing well. And then the bullseye again tells you which part is sort of affected. You can see that predominantly it is the lateral and the anterior side. And also if you look at the LA strain also, the lateral part, the lateral wall is again less blue while the septum is more. And similarly, when it comes to the free wall strain, you see that the free wall strain is usually higher, but you see that the free wall strain is much lesser when you compare it with the GLS. So these are sort of, just findings which sort of explains what is happening. Then when it comes to management, of course, most of the times it will be surgery. So they have to strip the pericardium, and this has got its own sort of problems, and that is left to the surgeon. And sometimes it's successful, sometimes it's partially, and sometimes it may not be. So that again depends on how bad the pericardium is. Then you have these other terminologies. You have the effusive constrictive pericarditis. So you have a tamponade-like presentation, and then there will be an underlying constriction also. So the moment the tamponade is released, the tapping is done, the patient continues to show signs of constriction, and this is an effusive constrictive pericarditis. So it's a separate entity altogether. And then you have these transient constrictions, and then you have these localized constrictions. So that again is a different area altogether. And then you have this sort of multimodal approach where you can look at each of these parameters and what favors, and then you have the CT, MRI, and especially this would be useful in difficult diagnosis where there is a diagnostic dilemma where the findings are not so straightforward. So you need to put in all the parameters and try and find out whether it is really constriction or whether it is some other, especially if it is restrictive cardiomyopathy. So that would be about it, and thank you for your patient hearing.
The dots with inclisiran, which is a new kit in the block for the treatment of hypercholesterolemia. The agenda of today's topic will be prevalence of elevated LDL cholesterol levels and then scenario. Then we will talk about the variability and the risk of cardiac events and how do we connect the adherence and variability and few takeaway points. So why is it important that we are to give so much importance for the cholesterol medications? Patients with ACS are prone to recurrent events. As all of us know, 1 in 10 patients report a second MI or a stroke or a CV death within the first 100 days after experiencing an heart attack. And more than 10% of the event rates of death, MI or recurrent ACS are reported at the end of 1 year. So progression in this coronary and systemic atherosclerosis is the main cause of recurrent cardiac events. So what it becomes an important and integral part of the treatment is the lowering of the LDL cholesterol, because LDL is one of the top modifiable risk factors, as all of us know. And the guidelines also recommend reducing the LDL cholesterol to less than 55 milligrams per deciliter of this thing. And the new guidelines, EAC guidelines 2023, LDL cholesterol of less than 55 milligram per deciliter is the target, or reduction of at least more than 50% from the baseline. And patients who experience a second event, they need to have a LDL goal of less than 40. So there is a huge unmet need for LDL cholesterol goal achievement among the Indian population. This is the real This is the real world data. Around 80% of the post ACS patients do not achieve the target LDL cholesterol levels despite taking statin therapy. Almost 80% of them, the target LDL of less than 55% is not achieved. And in about 55% of the patients achieve the LDL cholesterol of at least less than 70 milligram per deciliter. So why is it important? There's a new concept of cumulative exposure to the LDL. There's a new concept of cumulative exposure to the LDL cholesterol. As we age, the cholesterol that the body is exposed. So in this, I don't know, the pointer is not working. In this, the red dotted line that separates the patients from low risk to the high risk, that cumulative exposure to at least 5,000 milligrams of LDL cholesterol is the cutoff. As we age, the cholesterol exposure to the body is high, and once it crosses this 5,000 cumulative exposure, the risk also proportionately increases. And why LDL cholesterol is important? Because we have a lot of studies that have shown, more than 200 genetic studies and more than 2 million population studies based on the cohort studies, and randomized trials of more than 150 million CV events. So this is the kind of data that we are dealing with, and that is why reducing the cholesterol is very important. Not working. Yeah. So LDL forms the independent predictor of the cardiovascular event. For any increase in the LDL cholesterol variability, there is at least 16% increase in any coronary event and 11% increase in any cardiovascular event, and there is an increase of 23% death whenever we have this high LDL cholesterol variability. And real world data reports also show that a progressive lowering of LDL cholesterol variability significantly reduces the risk of CV events and all-cause mortality. Why is it jumping? So one of the main problems. Why is it jumping? Yeah, one of the main problems with lipid lowering therapy is the medication burden. So if you see the graph on the left side, the number of pills the patient on statins, you will have to take at least 365 pills. And monoclonal antibodies, if somebody is taking, almost about 26 injections. And the new kid in the block, that is silencing, gene silencing, RNA silencing, this thing, that you will have to take at least 2 injections, and vaccinations and gene editing at least once in a lifetime. So there is higher chance of medication burden on the patients. That is why there is poor adherence. And this is where the gap can be filled up by the new therapeutic agents like inclisiran. They result in effective and sustained LDL cholesterol reduction and are associated with lower administration frequency. That is, you will have to give at least, 2 or 3 injections in a year. And that way it helps in the adherence and feasibility of the dosing regimes. So poor adherence to statins and lipid variability. The main reason for poor adherence is the perceived side effects. The patient feel that the muscular side effects and the renal dysfunction, these are all mainly due to the statins. And also one more thing is the perseverance that Alzheimer's will increase in the elderly patients who are on high dose of statins. So they tend to not take statins as prescribed. And patients' cost is also one of the issues. Refill issues is one of the issues, and difficulty in remembering to take the daily medication. These are also one of the main reasons why there is poor adherence to the statins, and which increases the lipid variability. So if you see this non-adherence to LLT, that plays a very crucial role and is associated between the side effects and the worsening of there will be increased events. So poor statin adherence and lipid variability will increase in the LDL cholesterol variability, which in this thing exposes to the increased average LDL exposure, and it diminishes the benefit of the statin therapy. If you see the data, only around 15% are initiated on the high intensity statins, and out of which around 22.5% are switched to moderate or low intensity regimes once they go out of the hospital and follow up with the primary physicians. About 53% of the patients discontinue statin therapy about in 1.5 years of the post event, which significantly increases the ACS hospitalization and recurrent event. That is why there is a need for lipid lowering alternative therapy, which can reduce this kind of problems and which can increase the adherence to the statin therapy. So I will put up 2 or 3 real patients whom we usually come across in the hospitals. The right end of the corner is the young patient who has recently undergone an angioplasty because of the enstomy, and his medications include an atorvastatin of 40 mg and ezetimibe of 10 mg. And the middle patient is an elderly man who has already undergone 2 angioplasties in the last 3 years. He is on rosuvastatin and evolocumab, and his current LDL is around 80. And the last patient is a middle-aged female who has undergone angioplasty for a multivessel disease, and she is on 20 mg of rosuvastatin and 10 mg of ezetimibe, and our current LDL cholesterol is around 120. So how do we treat these patients? So if you go back to the Cardiology Society of India guidelines and see how do they classify and do the risk assessment, patients who are on the low risk, that is, there are no risk factors, the target for them for the LDL cholesterol is less than 100 milligrams per deciliter, and the non-HDL cholesterol should be less than 130 milligrams per deciliter. And patients who are at high risk, those who have a diabetes or with 1 or more risk factors, or a CKD with a EGFR of 30 to 59, or familial hypercholesterolemia without any risk factors, or hypertension plus 1 more risk factor, or hypertension with target organ damage. For them, the target of LDL cholesterol is less than 70 milligrams per deciliter, and the non-HDL cholesterol should be less than 100 milligrams per deciliter. And patients who are at very high risk, already who have experienced a event, or patients on imaging who have more than 50% lesion in any of the 2 major vessels, or diabetic patients who are more than 20 years of diabetes and have target organ damage, or familial hypercholesterolemia patients with already an event, and a CKD patients who have EGFR of less than 30 ml per minute. So these are very high risk patients, and these patients require a very stiff target of LDL cholesterol should be less than 55 milligram per deciliter to prevent any further episodes or onset of any new episodes. And the extremely high risk here, first initial dose that we give at the baseline, and after that followed by 3 months, and after which we give every 6 months one dose. It can be easily administered and the drug need not be refrigerated. So this way it is easy for the patients who want to take this therapy, and even if they don't, the chance of forgetting the therapy or the daily dosing is not there. So what does this addition of inclisiran mean to our patients, like the previous patient that we discussed? It has got a convenience of twice yearly, and it also maintains, it helps to achieve the guideline directed recommended LDL cholesterol targets, and it has got a very good safety profile, and it is very well tolerated. So with that I would want to, and it is very much well tolerated. With that I would want to leave you with these messages. There is increased LDL cholesterol is directly linked to the risk of atherosclerotic cardiovascular events, and sustained long-term LDL reduction is associated with the proportional decrease in overall lifetime risk of ASVD. And despite high intensity statin therapy, LDL cholesterol may be elevated because of the poor adherence, and inclisiran definitely has got a robust and durable reduction in LDL cholesterol levels, and it is a very strong complement to maximally tolerated statin therapy, and it comes with a convenience of 2 doses a year, demonstrates an effective and sustained reduction in the LDL cholesterol and a favorable long-term safety profile. Thank you.